Thinking about radium-223, it's been on the market now for 5 years. You use it in your practice, Nick. What do you think is the rationale for starting radium-223 before symptoms? Because the current label will say symptomatic prostate cancer. Do you think there's a rationale for using it before symptoms?
Well, I guess the lesson from the STAMPEDE trial in particular, and Latitude and CHAARTED and the other trials like it, is that early use of effective therapies generally is better than late use of the same therapy. So it's a reasonable thing to test in a trial, therefore. Now, in the ALSYMCA trial, this was dates from a time when there was only one drug available, and only half the patients in ALSYMCA actually had that, and that was docetaxel. And it was actually a very clever trial design, because they didn't partition it up as the abiraterone and ENZA trials did into the pre or the post-docetaxel space. It was, you just stratified by whether or not the patients had docetaxel. And that trial very clearly showed not palliative benefits, but survival benefits and reductions in SSEs, both of which are clinically meaningful and clinically valuable things. So one way of looking at the ALSYMCA trial is at least half the patients, it was their first-line therapy and it produced a survival advantage. So you've got level 1 evidence that radium produces a survival advantage in the first-line setting. Obviously, where you run into problems is where you've got other competing first-line settings, and obviously the symptomatic requirement in ALSYMCA, which is a bit of a sort of slippery thing, defining who's got symptoms, as Noel just said. Because I think often people don't realise they've got symptoms until you make them better.
Yeah, exactly.
Yeah, they think the backache and stuff that they thought was old age was actually their bone mets.
Yeah, exactly.
So I think it's hard to know how to interpret all of these data.
Yeah.
And
but the symptom requirement was largely to try and get an earlier result from the ALSYMCA trial. But in clinical reality, I mean, most of these patients have some form of symptoms.
Yes, and we put a lot of patients in the ALSYMCA trial, and for most of those, they didn't have very much in the way of symptoms. They went in my centre because they'd had a single fraction of radiotherapy.
Sure, yeah.
So you only had to have one MET that was symptomatic enough to justify a single shot of 8 Gray, and they were in. They didn't necessarily have to have very much disease at all.
Yeah, yeah.
Other centres obviously would have had different. I mean, we followed the rules, but rules, yeah, they're exactly what you end up with depends on local practice.
Yeah, there's quite a spectrum of symptoms in that trial. There's some patients who were on opiate analgesia regularly, and then, like you say, there were patients who had previous external beam radiation.
Early on in ALSYMCA, those predominated, and the trial almost failed because there was simply too many of those, and nobody was living long enough to even get the radium. Yeah.
Yeah, I think, I mean, ALSYMCA was a bit of a dirty trial, wasn't it? It was practical, it addressed an issue. So half of the patients had docetaxel up front and half of them hadn't. The PSAs were dichotomized, they didn't really have detailed scanning and so on. One thing which was very interesting in the sub-analysis, Fred Sard, who's a professor of urology in Montreal, has done such a huge amount of work in this field and other fields, sub-analysed this trial for those who were using bisphosphonate and those who weren't. And 50% were and 50% weren't. And interestingly, when you looked at the skeletal event rate, and particularly fractures, that bone preservation effect was completely lost in patients who weren't having bisphosphonates, which I think plays into what we've seen and are going to discuss in ERA-223.
Yeah, so this brings me nicely on to ERA-223. So data being presented this week here at ESMO, and it's a randomized trial. Patients with castration-resistant prostate cancer randomized to receive abiraterone or abiraterone plus radium-223, and there was a placebo-controlled trial. So the conclusions from the study, Nick, would you like to summarize those?
Yeah, so the rationale behind the trial was that we knew that abiraterone reduced symptomatic skeletal events. We knew that radium reduced symptomatic skeletal events. There seemed to be every reason to think you could safely co-administer these two drugs, non-overlapping toxicity profiles. And the primary outcome measure for the trial was time to SSE, the hypothesis being that two things that reduced it would reduce it even more and you'd see a benefit. And so what happened was that the trial was stopped early by the Data Monitoring Committee because there was an excess of SSEs in the abiraterone radium arm, and that in turn translated into a slight excess of deaths as well. So obviously two very good reasons to stop a trial, and the number of extra fractures was large. The interesting, so on the face of it, when the first press release came out, you're thinking, well, how on earth have two effective therapies made you die quicker from prostate cancer? And the answer is that they don't make you die quicker of prostate cancer. There's no, if you look at the cancer-related outcomes, there's no difference between the two arms. But that comparison is underpowered because the trial was stopped early, of course. What you see is a big excess of early fractures in patients who are not on bone protection. And what you see also is quite a substantial number of early fractures in men just on abiraterone, let alone on the control arm, let alone on the experimental arm. So, and that rate of fractures was substantially reduced in the men in the trial who had either denosumab or zoledronate as well. I have to say, in my practice, you've got a cannula in every time we give them radium, we give them a shot of zoledronate.
Likewise, yeah.
And we haven't seen fracture problems in my practice. Yeah. And interestingly, at a famous London hospital, where they have a pretty anti-bisphosphonate view, talking to their radiologists, they see a lot of fractures.
Yeah, it's interesting. I've had that same conversation, yes.
Yeah, and I'd be interested to see whether they change their practice now.
I think they have.
Do you?
I
Okay,
think they have.
yes.